in the kind of chat feature, but definitely have our commitment that we'll make sure that we answer any questions afterwards that we don't cover during the next hour and a half. The agenda's quite tight. There's lots to get through, and I'm really keen that we keep to time and we make sure that we hear everyone speak, including Cliff Mann, who's speaking at the end of the day, who's the National Clinical Director for Urgent and Emergency Care. So I'm keen to make sure we give him the time and hopefully for some questions as well. I'm an IT dunce, and so Lauren is running all of the IT section. So thank you. Next slide, Lauren. So really briefly for me, in terms of setting the scene, I guess the question for me is, why are we all here today? And for me, this feels like a pivotal moment for urgent and emergency care in the NHS. For many years now, we've had a deterioration in the key tenets of healthcare. So that kind of tricky triangle of quality of care and performance and finance have all been challenging and compromised over the past few years, and gradually getting worse and worse. And that's culminated in the year 2019, 2020, where there was, as we all know, extreme crowding in our emergency departments and clear patient safety issues. And then came COVID, and for years we've tried to do all we can to reduce attendance demand, to reduce admissions, and to lower our bed occupancy. But if we're honest, we've had very little success. We haven't done that as well as we could have done. But COVID has shown us that it can be done. We've had a 40 to 60% reduction in attendances. We've had bed occupancy down in the 60 or 70% bracket. But we now can all see those numbers are starting to rise again. And that for me is one of the key things about today, is the role that same-day emergency care plays in this work, and how do we maintain or even build on some of the huge gains that we've made during COVID. So for me, this is where same-day emergency care has a big role. If we do this properly, it does all of the following. It ensures that patients are seen by the most appropriate clinician first time. We make sure that we reduce preventable admissions, leading to a lower bed occupancy and reduced exit block within our emergency departments. And obviously it reduces crowding, and so it's right for patients, and it's right for staff. Next slide, please, Lauren. We've got, as I say, we've got a packed agenda with some fantastic speakers covering a whole range of different kind of content related to same-day emergency care. We've got the Accelerator programme, a regional view from Dee, James Ray, who's leading on London, Think 111 First, will give us an update on where they are with the London pilot. Y Valley presenting, Ian doing a presentation on frailty, Jyoti presenting on South Warwickshire, and then Cliff finished around same-day emergency care in the direction of travel in 2020. So that's it for me. So we'll try and keep to time, and I'll hopefully steer the ship in roughly the right direction if I can. And I'll hand over to Andy from NHS Elect.
Good morning, everyone. Are you doing my slides, Lauren? I think you are, aren't you?
Yes, I will do.
Fab. So I've got, in my usual way, I've got about a gazillion slides, but I won't be talking to all of them. But I thought it would be useful to give you some of the background data, and you can look at the key messages that I want to pull out from it. So the AEC network have done an accelerator program which really focuses on high impact changes that systems can make to really optimize their same day emergency care flow. And we've looked at about 4 or 5 organizations already in each region. So that's given us a big data set across the country. But also we're doing some further work with some of the regions, so we're going to have a much richer and richer data set as this work moves on. So things to understand about SDEC in the system is is how that flow is moving and whether it really represents a shift from admitted care to non-admitted care. And we can start to do some kinds of breakdown by looking at alignment with the ambulatory emergency care directory. That's one way of doing it. Or you can just look at 1 to 3 day lengths of stay. The way we've done this analysis is looking at the directory. So we've got a set of codes that we feel are representative of the things that we really would expect to be going through same day emergency care. It's not exhaustive, but it's certainly a start of 10. So this is actually analysis from the Midlands region, so particularly pertinent for this particular session. And we can see, if you just go on to the next slide, actually, Lauren, the kind of so what from that diagram is that there is still some further potential. So a lot of times people think, oh, well, we're already seeing a lot of patients. Is there really that much more to see? But the suggestion there, looking at the codes that are in the directory and what is and isn't going through SDEC, suggests that there is a significant portion that could shift. And if you're looking for where those patients are in the system, those codes can identify about half of those missed, inverted commas, patients. So if you can go on for me again, Lauren. Really useful to know how long patients are staying in ED. That's, for most organisations, that's at least half of their patients that go through SDEC, and in many systems much more than half. So understanding if there's any bottlenecks in getting those patients through to SDEC where they're actually going to receive their care is really important. And we can see that for Midlands, who are represented in this, there's some really good early streaming already going on. So that's something really important to build on. But we still do have a little bit of maybe a kind of a panic, for want of better words, coming up to kind of the 4-hour period where suddenly a lot of people are pushed through. And then there is also another kind of long tail of waits as well. And if you go on to my next slide, please, Lauren. So there is this kind of bit of a breach panic, maybe. Panic's a bit of a strong word, but there is certainly that behaviour around, oh, we need to move this person. And that long tail, the organisations where we do see that long tail, when we kind of drill down into what's going on there, it tends to be a bit of a behaviour of, rightly or wrongly, but a bit of a behaviour of, well, this person's turned up, it's 2 o'clock in the morning, they are going to be right for SDEC, but I don't want to send them home at 2 o'clock in the morning just to come back at 10 o'clock to be seen by SDEC. And that may well be the right choice for some patients, unstable, elderly, frail patients late at night who are going home to an empty house. That might be the best thing for them. But actually, I think there's some challenge that can be put in there about, have we actually asked the patient what they want to do? Do they want to go home and come back, or do they want to stay here? And what are our out of hours processes that would support a home and come back approach to SDEC, rather than holding people for prolonged periods in the ED. Next slide. So looking at case mix, really important. This is, again, case mix for Midlands of what is actually seen. And there's no great surprises on there. That is a fairly typical spread of different conditions. Low risk chest pain, from a medical point of view, we know that is a large chunk of the patients that turn up to our secondary care services. And from a surgical point of view, we know that tummy ache is a big chunk of activity there. But it's just useful to understand kind of where we already are with what we're seeing, and maybe are there further things that we need to do with other subspecialty services to capture some of that activity. So there's a few gynae things on there. So what's the early pregnancy emergency gynae offer as part of SDEC. So there's things like that that you can start to consider. Go on, please. Kind of combined with that, to understand that case mix, is whether people are being admitted or not. So we would expect about a 10 to 15% conversion rate from SDEC. There's no absolute right answer. It's about being curious as to why it is whatever it is. But around 10 to 15% suggests that a reasonable amount of clinical challenge is being taken on the patients that are being pulled through to SDEC. So where you've got a lower conversion rate, what's driving that? Go on for me, Lauren. So is it about risk aversion, or is it actually that you've got some really good other services that are picking up this work and doing it same day, but aren't being counted as same day emergency care? So there's some investigation to do on that, to understand, is it the types of patients you're seeing, is it the acuity of those patients, or is it that you're not capturing all of the good work that you're doing? Go on. Timing is often something that's picked up as well. These patients all arrive in the middle of the night. We wouldn't have our SDEC offer open, and so on and so forth. So we can look at that alignment, and that's something really useful to do within your organisation, to understand where you are seeing your patients and where the missed patients are turning up. There's two ways of looking at it. You can look at it as arrival time of those missed patients, or on the next slide, you can look at it on when those patients are being admitted, if they're coming in. They offer slightly different views. I'm not sure which one really is more useful, and I think it's most useful to look at both to understand exactly what's going on. So is the, if you go on to the next slide, is the pace of SDEC being continued into the evening, and is that supported by the things that you need? Is everything just closing down at 5 o'clock, 6 o'clock in terms of diagnostics, in terms of being able to access community services? And is that preventing you continuing your SDEC? Or have you slightly misaligned your hours with your demand? So again, this is something to look at and something to be curious about. Go on. And then you can also do some analysis. And if you can just flick through to the next so what slide for me, Lauren, you can start to look at who the missed patients are. Are they 1 day length of stay, 2 day length of stay, 3 day length of stay? And what we tend to see as we go through those different time frames is that those people who are staying for a little bit longer, but probably still have a good chance of going through SDEC, much more likely to have a frailty type picture. So when you start to look at the conditions that are coming up there, they're the falls, they're the UTIs, which are probably only coming in because they've also got some delirium with them, and so on and so forth. And there's a big potential still for surgical same-day emergency care. It's a slightly newer version of same-day emergency care, so that makes sense. But something to work on, I think, for most organisations really, is to really have a robust offer for that. And if you go on again. So we also don't just look at numbers, we looked at individual patient journeys to understand the whys and the wherefores. If you go on for me. We essentially do a right person, right place audit, and we divide people up into these different boxes. This again is for the whole of Midlands region, and if you go on for me again, and we can look at patients in different parts of the system. And what's interesting on this, and is replicated in the national data as well, actually, is that the kind of the size of the missed patient population is kind of equal to the size of the patient population that's going through SDEC that probably doesn't need to be there. They should probably be in an urgent outpatient clinic, or completed in ED, or completed by their GP. So often the conversation is around, well, we couldn't do any more activity, we're already at capacity, but actually there's the stuff that needs to be shifted out, so the stuff you want can be shifted in. And if you go forward again,
Andy, we'll need to stop.
That's fine.
Sorry.
That's kind of it anyway.
Any other final kind of key messages for anything else you'd like to just finish off with, really? So what was really good about doing this analysis across the country is it really does show the difference that organisations are making. Even with quite small services, it can make a huge difference. So it's just about being curious about whether the thing that you set up because you had to set something up is actually based on the demand, or was just based on what you could do at the time. And starting to unpick that now is a really good opportunity, I think. Brilliant. So there's lots of information within the slides. So make sure that all the slide pack is sent out to everyone to have a look through, and then all the presenters are more than happy to have individual kind of comments and questions afterwards. There's a few things on the meeting chat which we've covered some of them during the presentation, and other bits we'll make sure that we answer afterwards. But thank you, that was really, really helpful. Thanks, Andy.
A pleasure.
So on to Dee Henry, giving us a really key piece of work around attendance and admission avoidance and getting people to the right place first time is Think 111 First. And so we've kind of linked in the same day emergency care presentations and content with Think 111 First. So we have Dee giving a regional update, and then we've got James Ray giving us a sort of London and national update. So over to you, Dee.
Hi, thank you. Good morning, everybody. Due to Wi-Fi restriction, I won't be putting my video on. Apologies there, but I don't want to lose connection. So just to put a bit of background to this, on the 29th of April, Simon Stevens and Amanda Pritchard's letter was published, and that was titled The Importance for Action, the Second Phase of the NHS Response to COVID-19. Amongst other things, this letter described the opportunity to lock in beneficial changes that we've collectively brought about in recent weeks. This includes rapid scaling of new technology-enabled service delivery options, such as digital communications and consultations. It talked about strengthening 111 capacity and increasing the availability of booked appointments, and particularly the opening up of secondary care dispositions. And they named explicitly SDEC, hot clinics and frailty, and that's to allow patients to bypass the emergency department altogether where clinically appropriate. It talked about encouraging people who should be seeking emergency and urgent care to contact their GP, go online to NHS 111 or call 999 if necessary. So this has been translated into what is currently known as the Think 111 First programme, although we are expecting the name to change. There are two key elements to this programme. The first is to ensure that unheralded patients presenting to ED are streamed to the most appropriate service, off-site if necessary. And those patients that do call 111 and have an ED disposition are booked a slot in ED or an alternative service in the hospital, and that includes SDEC. So the approach that we're taking across the Midlands is based on learning from the pilot sites down south and applying that locally. We've looked at various options, going full-scale implementation, trust-led, because we do have some very keen trusts who are driving this, and 111 provider-led. Each model has its own risk and unique selling points, and the key areas for our consideration included those listed on the slide in front of you. Ambulance pressures at the front door were key to this, so we're already seeing patients returning to EDs, and we're starting to see those delays outside ED departments as patients wait to transfer from ambulance to ED. Engaging the public through various forms of communication is key so that we can get targeted message, and respecting the fact that any communication to the public that won't respect the geographical boundaries. Once the message is out there, it's impossible to control it. We want to ensure that our 111 providers are not put under immense pressure. So having the ability to support each other while recognising the obligation to support others nationally if they go into national contingency. Looking at the call handling and clinical resource capacity in our 111 providers, the technology and the interoperability that we have already in the system, and the limitations that we have where services are on various different models, and financial investment, both capital and revenue. And at this stage, there's no investment in either of those at this point, but we are hopeful that there will be some financial support. Next slide, thank you. So the recommendation that we've gone with for the Midlands region is that we go with WMAS as our early adopter site as a 111 provider, with Hereford and Worcester being our lead trust. Now, the key justification for this was the balance of risk, the keenness to drive forward quickly, the impact on the wider system and the pressures, particularly those at the front door of ED, and the maturity of the technology to book patients into primary care in that area. At the same time, we'll be working very closely with Hereford and Worcester to adapt the model and design the model that works for their health economy. And at the same time, we'll be replicating this in Leicestershire and Lincolnshire with the DHU 111 provider as we share the learning from Hereford and Worcester, and then rolling that out across the remaining STPs before moving across to Staffordshire. Now, at any point we find the capacity and demand modelling is inaccurate, we can pause and rethink the approach. And again, at no point will we be consciously putting any provider at risk due to significant increases in demand. So there are key risks to this. The list is significant, but the high level programme risks are in relation to finance. Sorry, Lauren, next slide, please. So the high level programme risks, if we group those, it's very much around finance, it's around contracting, it's around national contingency, it's about interoperability and technology. Obviously, COVID is key here because we are potentially, or we haven't come out of the first peak, going into the second peak, and our winter preparedness. So our timescales are tight to get this right. Now, luckily, we do have some risks around system-wide engagement, but we've got a lot of engagement from all of our providers at the moment, which is very positive. Timescales are also tight for implementation. We're looking to get the first site, Hereford and Worcester, going live with a model by the end of June. Next slide, please. So the governance to this is key. So to ensure that we put this model in place across the whole of the Midlands region, we can't have systems developing their own models in isolation. So as you can see from the governance slide, we have a programme board, and underneath the programme board sit 4 key work streams. Now those 4 work streams, you can't quite see the detail. It's capacity, demand and workforce, digital and technology, clinical, including the wider pathways, and communications. And communications is to the wider public as well as our healthcare professionals across the STPs. There will be virtual task and finish groups, and then the stakeholders around the outside will be represented into those task and finish groups. We've got leads for each of those work streams, and we'll be working very, very closely with each of the health economies. What we're starting to do at the moment is work in relation to Hereford and Worcester. And to draw this particularly in relation to SDEC, we will be taking work stream 3, the clinical, including the wider pathways, and work stream 2 from a digital perspective. And those 2 work streams will work very closely together. The membership of those work streams will include stakeholders from across the 111 provider, across Hereford and Worcester, finance, mental health, primary care, DOS leads, etc. And we'll be looking to get a model that works right for Hereford and Worcester. We will be working with the digital team to get direct booking from 111 directly into SDEC, and ensuring that the patient information from the ones will transfer directly to the provider. So when the patient does arrive, all the information that's been captured so far will transfer for the patient. I'll pause at that point. There's a lot more that I could go into detail on. Does anybody have any particular questions? Then could you put them into the comments box and I'll respond to those now.
Great, thank you, Dee. Yeah, there's been a few questions. Really kind of exciting and important piece of work for the region and for nationally. So that was really helpful context. So we've now got James Ray, who's an ED consultant in Oxford, done some incredible work on 111 over a number of years, and is leading on the London 111 part of the national project. Thank you, James. Over to you.
Thanks so much, Dan, and thanks so much for inviting me as well. Just to emphasise that, so the 111 First programme is all about getting those patients who with urgent care needs, instead of just walking into A&E, to actually think about either going to their GP or ringing 111 or going online first before doing that. And the overall aim is to reduce nosocomial spread simply by reducing any kind of crowding within waiting rooms. So it's a really important program which has now got sort of national interest, and we now have I don't know if anyone saw the article yesterday in the Times, but also it's going through number 10 today, and they're fully supportive of this program, so that's all good to hear. So I don't know if you're probably aware, but 111 refers patients. How it works is it has an algorithm that uses pathways, and when a patient calls 111, they go through the algorithm. About 7 to 8% of those outcomes get referred into ED. So I think for me, for people who aren't sure of the system, one of the most exciting things about the program is that connectivity between the acutes and the 111 service and the pre-hospital space. For the first time, there's a real opportunity to engage those two services together, so that we work together, so that the patients do actually get the right outcomes, and we get to see where patients actually go and have influence in where they end up. So one point I wanted to make, there's two areas I really want people to think about. One is something called clinical validation. So when a person calls 111 and they get an ED outcome, if we sent all of those ED outcomes straight to ED, and ED were aware of them, they'd probably get fairly cheesed off very quickly, because quite a few of them, because the risk averseness of pathways are quite, in some ways, quite inappropriate. But after validation, we should get greater accuracy in terms of the ones that are appropriate for ED, but even more so appropriate for same-day emergency care. So these are patients that potentially have important clinical problems, but not necessarily emergency problems, that would normally end up going to A&E, and A&E having to refer them either to SDEC or back to the GP to refer them to another service. So these are the sort of people we want to capture. So to do this, to sort this process out, we need to sort of get the basics right, which is what this slide's all about. So it's about 111, getting the right workforce. If we're going to start sending all these calls from the patients that would have been walking to A&E, now having to ring 111 or potentially their GP, we've got to think about increasing our workforce capacity. We've got to think about increasing the clinicians within that workforce so that they can validate all those cases. And the other benefit as well is that we now, in London, we now have the shielded list. So we're actually being able to herald shielded patients into the ED for the first time, which is incredible. So that EDs are able to actually prepare for patients that are shielded. I think I'll move on to the next slide if that's okay, with the limiting time. So this slide's really just to show you the flow of patients from 111. And it's a very London-specific slide, because the PRM is a separate telephony system that only London has. So just ignore that bit, but everything else is absolutely accurate. So if you just follow the phone 111 middle section, it goes through a health advisor. We should be able to find out at that point whether someone is shielded or not, and then it will go through potentially an ED outcome, where it goes into the CAS, the Clinical Assessment Service. And the when it hits the Clinical Assessment Service, they utilize something called the DOS. And this is really, really key, because I think at this point, clinicians within the system who receive referrals from 111 need to understand the DOS. And I think it's the clinical engagement with that understanding, the directory of service, which will really make a difference to outcomes. Because if you know why patients are sent to you, and if they're not right, and you can then change how that referral process works, and influence change for the future and improve quality of those referrals. And if we don't have that understanding of how 111 works, then we won't be able to do that. So once we've been through the clinical assessment service, we can then signpost or book patients into services. And the reason that for the black and the green, the black is simply what we have at the moment. Now, we know that when people are signposted, it leads to aberrant behaviour. So patients end up, if they're signposted to primary care, they'll often end up walking into ED because it's easier. Or sometimes if they're signposted to ED, they sometimes think that's a bit over the top, so they won't go. So they'll use some other service. So signposting, we know, doesn't work that well. So the future is all about booking. So that's why booking into ED, although it sounds like a really odd term, is really important, because it's all about connecting the patient and actually following that patient journey. So booking people into an SDEC pathway is a real opportunity. So we can move to the next slide. And I think the next slide after that, I think it's just an easier version of the one before. So I discussed this slide in a clinical meeting in London, where we looked at 10 common outcomes from 111 that end up with an ED outcome, and how they can be changed. Now, this isn't, what is the future. This is just potential. So this could be changed in all kinds of, cut up in all kinds of different ways. But essentially, when these patients go through a clinician within the system, the clinician has an opportunity then to refer those patients directly into services. And how that's done is really going to be the complexity and the devil in the detail part of this program. So an example here from those 10 cases, 4 of them we put into SDEC. So one of them was, someone with, so the red one is chest and upper back pain, which is, I'll come to in a minute, is the commonest outcome for ED, the low risk chest pains from the 111 algorithm. Another one was a swollen leg leading to a DVT potential. And the other one was someone with a headache that was persistent, that was giving signs of potential raised intracranial pressure. And the final one, I think, was an ambulatory one for a frailty. I know it was a heart failure patient, so someone with shortness of breath over a long period of time on diuretics, who was referred to SDEC for a heart failure assessment. So can you go to the next slide? So in London, we've looked at the top 20 outcomes that lead to a 1 to 3 day length of stay. And I think I just wanted to put this up here in terms of just mapping the conditions. So looking at, targeting conditions from a 111 perspective. So some of those you can see will be very easy from a 111 perspective, because people present with chest and upper back pain, they present with early pregnancy bleeding. There are more complex issues, aren't there, like abnormal liver function. There are pathways that you only really appreciate once you've actually got the diagnosis. And you've got to understand that from 111 perspective, that they deal with symptom groups and symptom discriminators. So if you go to the next slide, what we did in London, we looked at just one area of London, one of the 111 providers, and we looked at the top 25 1 hour and 1 hour, and we looked at the 4 hours as well, 1 hour ED outcomes from 111 pre-COVID and then during COVID. And without doubt, the highest of them all, which remains the case, is the low risk chest pains. But if we sent all of those low risk chest pains to SDEC, I think we'd drown the resource, and very soon the clinicians within the service would get upset about those referrals. So these cases need to be validated, and when they've been validated, that number will reduce quite significantly. When we audited post validation chest and upper back pain for a clinician just taking a referral over the phone, we reduced the outcomes from to about I think it's between 25 and 30% of the actual chest and upper back pains that needed to go into the hospital. The rest of them went to self-care or primary care. Another one that's come up that you've got to be aware of from 111 that needs sorting out is something there which is quite high, called predetermined management plan. Now, if someone has a chronic condition and their GP says, look, whenever this happens to you, you just need to go to an ED. Then when they ring 111, they tell that patient, so that the call handler, that they have this problem. They get dealt with as a predetermined management plan. There's no clinical information passed through. They don't go through a clinician. It gets straight through to ED. And if we see lots of patients with predetermined management plan as a symptom group, as a chief complaint, I think we're going to get a bit upset about that. So that's something we need to sort out, because I think what we're finding is 111 call handlers are using that as because the numbers are so high, potentially as a quick way of getting through the system. And also, I think we need to get more information. So it's all about understanding what that chronic condition is and what is the actual plan that was written by the GP that is required of that patient once they hit the clinical setting. So that's something that we need to work on, which we're doing some work on that this week. But next slide, please. So based on that, and based on the previous slide, the top 25, the London clinical leads in SDEC have put together, thinking about things like shielded patients, the actual volume of pathways, the top 12 in terms of what we should be focusing on from an SDEC perspective from this One First programme. And for each pathway, we have a clinical lead, which will be focusing on each pathway. So some of them will be hopefully fairly straightforward, and I think some of them are going to be very complex. For instance, the frailty ones, I think the asthma pathway is going to be particularly difficult, because picking up who could go to an SDEC, who needs A&E, and who could stay at home is going to be quite challenging. But again, we've got very senior clinical people in that pathway looking at that. DVT is a really good one. So I think 1-1 is pretty good at picking up unilateral swollen leg. So I think that'll be a very positive one. P is going to be challenging. I think that's going to be coming from the chest pain, chest and upper back pain, or shortness of breath pathway. But again, these are things that we have to sort of try out and see how they work. But there's certainly some huge opportunities to get these right and to improve flow of patients into direct care rather than into ED. What's the next slide? Next slide, please. And these are just literally the point that we're actually, we've got clinical leadership, and these are the early starters. The low risk chest pain is a real number one, simply because of the volume that comes from 111. The next slide, please. And this is probably really important, probably the most important one, because it's about how you do the process. One thing is having a clinical pathway, but how do you do the referrals from 111, from a clinical call handler remotely into a SDEC service? We need to think about the technology, how we're going to communicate the referral across, but also be able to communicate it so we can actually then investigate it later and assess quality. So it's business intelligence sort of achievable. So it needs to be done electronically rather than just a phone call and send the patient in. But I think we're looking at it's a method we use in Oxford for direct referral into SDEC, is what we call a DDI, which is a direct dial-in to a single number, where that number is held by a number of people, and it runs on something called a hunt group. So it'll be started off by one person and then to another, and so that call eventually does get answered, and it's always the right person that's at the end of the phone. And the other thing, how we'll send that referral in? Will it be by an email? Will it be by sending them straight into the ITK messaging into the EPR system of the hospital? So these are all the challenges that we've got to sort out, but it's something very, very important. But I think I'm going to end there, if that's all right. It's a brief sort of summary of everything. But happy to answer any questions either later or now.
James, that's really, really, really helpful. I mean, the clinical lead for each kind of cohort of patients is a really sensible approach. And I'm not sure other regions are necessarily doing that. That's something we can take forward within the Midlands, I think, if we've got the capability within our clinical teams. And then the bit about the IT solutions is really tough, but obviously you're working through that and got you're making good progress there, aren't you?
Yeah, and I think it's really good that we all communicate with each other, because some of us are going to have solutions that work really well, and some of us are going to try things and it's going to fail. And it's really important that we all learn from each other, because that will definitely happen. I mean, at the moment we're sending 111 referrals to ED in London by email, and the email title is the name of the patient and the age of the patient and the shielding status. So it looks like a patient list. It's not ideal, but we've got 27 EDs to work with, so we had to do something. But we're desperately looking for a better solution to that. So yeah, learning from other people would be great.
Brilliant. Thank you so much. There's lots of kind of comments going on the chat, which will I know that James is more than happy to take kind of queries and questions either via email or through myself or Lauren, and then we can hopefully continue to share good practice across the country. Really, thank you, James. Thanks very much.
Thank you.
So on to sort of some local things now. We've got James Bartlett, who's lead for acute medicine at Wye Valley, who's going to give a presentation on their experience during COVID. Thanks, James.
Thanks, Dan. Yeah, so we have the next slide, please. I'm the lead for acute medicine at Hereford. It's really just to sort of start off with a very sort of personal, local experience of what it's been like for SDEC. So just a bit of an idea. So at the bottom of the slide here, you can see the kind of the nice, neat and tidy idea of having SDEC or ambulatory emergency care set next to a large AMU where you can deal with the admitted patients, and an ED which is all nice and neat and tidily separated from each other. We've had a fairly blended model for some time with quite a large acute medicine presence in ED. So some of our same-day emergency care, as we would understand it, is actually delivered within the ED. Our CAU, which is our clinical assessment unit, which is mixed medical, surgical, orthopaedic, etc., unfortunately is an overspill bedded area. So we deal with some of the patients that you might expect to be on an AMU actually in the CAU, which then limits and alters the risk-taking behaviour that you can get away with in terms of SDEC and so on. And then an AMU, which is probably a little bit too small for the number of admissions we've got. So when you look at the amount of SDEC that we actually do, although it might appear neat and tidy that the 6 from CAU are the ones that then get converted along with our GP directs into SDEC, it's not quite as neat and tidy as that. And I'm sure other places will have similar but different experiences from talking to other colleagues nationally. It's just worth saying that our medical bit has been very well established. So you can see what we were doing in 2019, and we have a pretty good handle in terms of where our patients flow through our system from there. So that describes the average, if there is such a thing, day of patients flowing through. So we've been like this for some years. Surgical specialties have come to this rather later. So they came in just at the end of 2019 and unfortunately have suffered more in terms of a more embryonic service. We also have front door frailty, and we work with single clerking. So that's all where we were in 2019. Next slide, please. Then obviously everything got obliterated by COVID. So CAU was turned into a green ED. That therefore eliminated our physical environment for where SDEC was delivered. And I'm sure, like everyone else, we were trying to work out how we were going to deliver a fairly brutal front door respiratory failure pathway, and that was really taking all of our time and attention. Really the only SOP we gave to same-day emergency care was providing virtual assessment sort of down in that bottom left-hand corner through the green ED for the few meagre DVTs that we thought we'd be dealing with, and a few cellulitis here and there. So everything got washed away in terms of the physical environment. The staff were mixed into the main ED. So SDEC was not high on anyone's list of priorities when we were faced with the tidal wave. Next slide. So consequently, our medical take diminished by around a third, and of those, SDEC really evaporated almost completely. Again, that's not strictly true. We were delivering quite a lot of care that would be recognised as SDEC, and for medicine, that was sort of business as usual for us. So whether we were seeing the DVT in green ED, which used to be CAU, and then sending them home and doing it along a DVT pathway and so on, it was still SDEC. And we were seeing between 1 and 9 patients per day on the virtual CAU, even when our ED attendances got down to sort of just double figures, which was all very spooky, as I'm sure, again, it was for everybody else. But it just wasn't a big focus. We did the stuff that we did normally because it was embedded and ingrained. But in terms of labelling it as SDEC, that seemed a pretty low priority for most of us who were worried about what was about to come. As we've started to think about restoration, we've started being more diligent in terms of relabelling people as SDEC. And part of that is to do with the behavioural factors. We were informed by our ED team that by not having SDEC, that they had forgotten what it was, which was a bit of a surprise to us, but it was because we didn't need it. We didn't need it for a period of time. It wasn't important in terms of the things that we normally expect it to do for us in terms of helping with that capacity and dealing with people without resorting to admission. We had an ED which was much more empty than we were expecting, and we had wards which were much more empty than we were expecting, so we could afford to place people onto the AMU without any sort of fear or pressure. Next slide. But this then brings us to what do we do next? So up in the left-hand corner was the system as it was set up with this unhappy mixture of ambulatory emergency care and short stay in the CAU, which was disruptive to delivering SDEC, with this sort of normal pattern of community care ED, SDEC and short stay admission through the AMU. Over on the top right hand corner is the COVID setup. So community, everything was coming through this streaming function at the front door. And we had struggled to put streaming in place before, but all of a sudden it was an easy thing to do because we needed to protect green ED at all costs. And so we put this streaming function in right at the front door, but it was COVID or non-COVID, with SDEC being very much an afterthought. And then our AMU has transferred or changed into becoming a COVID pending area. So we're getting more patients through our AMU, but that's waiting for swabs. We've become very good at doing that, but that's not what we want to be good at in the long run. So the question is do we just go back to where we were before? And the answer to that is no. The question is what do we go for next? And the streaming bit of it, we'd like to try and retool into becoming a probability of assessment type function. So are they very likely to be admitted? Do we need to put a lot of resource into them to make sure that the sick patients do better, etc.? Do we need to, and then we want to cream off the very most likely SDEC patients, but really we see those as being an extension of patients who are sort of peri-admission, the ones who we could manage at home with a virtual ward environment. We're working through a work stream with that at the moment, which is daunting and exciting. And then the intermediate group, the ones who we would start off thinking they could be SDEC, but we know that that's going to be a tougher group to turn around. And then trying to use the estate that we've got to fit in with those streams of patients. We're at the beginning of that at the moment. Next slide. So I think the lessons from us locally was, I'm sure as with everybody else, is we couldn't do that to how do we do it by tomorrow because there's some missive from central government or from someone else or whatever else it is. A lot of that was COVID specific. So how do we deal with patients who are amber, blue and red and so on? Sorry, blue became red, didn't it? Or red became blue. Social distancing. So how do we use the car park and patients' cars as a waiting room, etc. These things have been good for our problem solving. But then there's the much more generic stuff, the stuff which we hope will serve us more along the line. So how do we deal with patients virtually? How do we use the estate differently? The IT solutions that we couldn't possibly implement were implemented within a day. Streaming, couldn't possibly do it, done within a day. You know, these things were really liberating for us. We didn't need SDEC for a period of time and it stopped. We just didn't need it. And I think there is something about the pathway and process visibility, and I think especially listening to the 111 elements of it just then, we are going to need to have some sort of concrete processes, but it's trying to make sure that those processes don't then obliterate the value of the sort of grey case type dealing with it. Mixing the staff was good for medicine, for the nursing staff, because ED and medicine got a better idea of what each other could do. But for surgery, that got completely obliterated because it was much more embryonic. So we're having to sort of start again with surgery, which feels somewhat disheartening, but it is what it is. And then, as I said, this idea that beds in SDEC are a bad thing is not news to anybody, I'm sure. But we have had the opportunity of watching as many patients as we would have dealt with in a day as we're reforming, going through a few clinic rooms with no beds, as we used to manage to get through a much, much larger space. So I think it helps to set for us the need to do things considerably differently if we want the behaviours to be different. So it's a very local experience. But hopefully there'll be some lessons that others can take from that. And from my perspective, I've heard all of the 111 stuff, and that sounds daunting again and exciting as well. So
thank you, Jane. While it was a local experience, it's I think a really powerful one, and to be able to just give the honest account that you have of some of the pace of change and a real life kind of lived experiences, I think it's really powerful for everyone to hear. So thank you very, very much. Again, there's been lots of comments, particularly around your kind of your honesty and openness. So thank you very much. Thank you for your time. Brilliant. So I don't know how we are, but we're running on time, which is thanks to no thanks to me and thanks to others. Moving on to Ian, who a lot of you will know from sort of Midlands and nationally from his work on frailty. He's going to give a sort of learning from COVID, frailty slant to SDEC over the next 10 minutes. So thank you, Ian.
Thank Dan. I hope everybody can hear me. Is that okay? Yeah. Can I have the next slide, please? So I was asked to do this just a couple of days ago. So apologies if some people have seen some of these slides before. So it's been quickly cobbled together. From a frailty perspective, the most important thing for me to stress, and it's already been stressed by the two prior speakers, is to be thinking about the whole system rather than just the front door or the acute frailty unit. And the more we move towards, as we heard from James in the previous talk about how we manage some of these patients in a virtual manner, that's going to be really important from for those people living with frailty who are really at high risk of nosocomial infection if they come to the wrong place at the wrong time. So this slide I've used many times before, and I think it's how we start having hospitals without walls. And we were seeing some of this happening across some of the systems in the Midlands, some with some good success, others with less good success, but actually sharing learning with each other. Can I have the next slide, please? So I think, you know, the crucial things that I wanted just to sort of talk about as an overview, and apologies for the one or two typographical errors. We all knew already that people living with frailty or multiple comorbidities are a very at-risk group. What we did see throughout this period, and still relatively ongoing, but starting to tick up now, has been a marked reduction in presentations to A&E of this group of patients, be that a good thing, in other words, that they were being managed appropriately out in the community, or potentially not quite a good thing in that they may well be deteriorating at home, as with other conditions. I'm going to touch on pre-hospital urgent care response and attendance avoidance, and how some systems within the region supported that from the acute sector, their acute frailty processes, to provide that in a virtual manner to provide quality outcomes for patients. I'm going to touch a little bit on care home response, because that was patchy across the region. There were areas where there was very good support going into care homes, others where it's still developing. And then obviously there's the A&E and acute frailty response. A number of units, as we know, actually stood down their acute frailty teams within the ED because the patients weren't turning up, and refocused those people's work elsewhere. And one of the questions we need to be asking about all the time is, we talk about criteria to remain for those people who are in hospital, actually about how we use criteria to remain more effectively for admission of attendance avoidance and admission avoidance as well. My biggest area of concern from across the region and nationally has been the lack of data on outcomes for this group of patients. As we all know, there's been a lot of concern, certainly from the care home sector, about what happened to them in the early part of COVID-19, but also there's the whole group of patients who were at home and either had attendance avoidance or had very early supported discharge back home. Do we have that data on their outcomes to be able to inform the future direction of services? Next slide, please. What was really apparent was the 2-hour response never needed more than now during COVID-19, and there was some really good examples of systems across the region stepping up and providing those responses. And what really strengthened some of those was obviously the very strong links that were developed between GPs and consultant geriatricians and the ambulance service and geriatricians to be able to respond and support people out in the community and getting that care support or treatment support coming in for those patients, and essentially doing SDEC out in the community. And that, you know, I go back to the original version of the Director of Ambulatory Emergency Care, where we stated very clearly that SDEC or ambulatory emergency care was not a place. It could happen out in the community, it could happen in the ED, it could happen in medicine, it could happen in surgery. It's the most important thing about AEC, or SDEC as it's now known, is it's a mindset rather than a place. There were some good examples across the region, mostly focusing on care homes. Stoke and Leicester did some good work, both of whom recognised that they were only at the start of their journey and needed to to work faster and further on those. What many systems that were doing this focused on was the treatment element and not the care and support and rehabilitation element, and it's how we can better integrate these rapid response treatment teams, and as I say, there was variability across the region with Pathway 1 home first predominantly. If we looked at pre-COVID, the majority of patients who were being admitted who had frailty actually had mild to moderate acute illness, and they're the group who actually we need to be really focusing on. One, they're now not turning up. Has that been a good thing because they've been getting their treatment out in the community? We don't know the full extent of their outcomes. Or is it a bad thing because they may have actually not been turning up and been functionally deteriorating? But they are really a group where this interface between the 111 system, the 999 system, ambulance, primary care, the 2-hour response, and outreach, virtual acute frailty has a real opportunity. And some of the systems were exploring this and actually delivering it in selected groups of patients, predominantly around care homes. Next slide, please. And I've already touched on this. The urgent care support to care homes was underdeveloped initially. It's still relatively patchy and needs to build up progressively across the region, but there's still variability. There's a real opportunity to properly consolidate advanced care planning, to have advanced care planning that describes the potential scenarios, but then doesn't say, if they have a treatable condition, please go to A&E, which is what I've seen in many advanced care plans across the country over the last 3 to 5 years. It's about saying, actually, if this person has a treatable condition, because the likelihood of developing, we're doing advanced care planning, what would be the response that we could provide out in the community, and what outreach support, to be that virtual support, could we get from secondary care to make sure that we develop a frailty sensitive approach. And we may want to start that, as I say, within the care homes, and then start expanding that to those living in their own homes with frailty, because there is a much higher proportion of patients with moderate to even severe levels of frailty who are living in their own homes than there are living in care homes. And now with the apparent shift of families not wanting older relatives with frailty going into care homes, we may need to get better at that. And the two specific examples that I want to talk about was the Stoke Crest team. I hope I've got that abbreviation of the team effectively. That really kicked up and was really supported. They developed that before COVID-19, and it really increased the support they were able to provide to care homes. And the Leicester, there was the direct liaison with the consultant geriatrician. That was the ambulance service being able to directly liaise with the consultant geriatricians, and they were able to support and appropriately avoid attendances in a very significant proportion of patients. Next slide, please. Again, if we go back to what it was like pre-COVID, one of my concerns nationally, both around ambulatory emergency care, SDEC, and frailty, was a very big focus on that we have to have a unit, and we need to have a geographical space where we're going to be doing this. And I cannot stress enough that the most important thing about both SDEC and acute frailty is that they are not just about a place. You do need, for some patients, an area to be able to do the assessments, but actually it's predominantly about a mindset. One of the things that that really became apparent during this process is that comprehensive geriatric assessment, which is if you identify somebody with frailty and you feel they need to come in, or they need to be managed through an SDEC pathway, people feel, right, we've got to complete the comprehensive geriatric assessment before they can go home. No, you don't. You can do the key elements, transfer home, and then complete the comprehensive geriatric assessment at home with an ongoing treatment and support plan at home, be that in the care home or within their own home. Again, I think we're moving forward, and what many people were starting to think about was assume that all those being considered for remission are SDEC, including the frail. I can't stress that enough, and that was actually the case pre-COVID, but I think COVID's really helped to focus that, particularly for this group of patients who are particularly at risk of nosocomial infection and then bad outcome. And the crucial thing is, obviously, if you can turn somebody around at the front, is making sure that you get that 2-hour response and then the home first response if necessary to support that person being at home to make sure they get the outcomes they require. I was still seeing the occasional patients being admitted with falls, and particularly being admitted to community beds during COVID-19. As a geriatrician, in my last years of clinical practice, unless they had another acute problem that itself warrants admission, falls never need admission to any bed, be that an acute bed or a community bed. They need to be managed at home with appropriate assessment, which can be done on a virtual basis, and then the necessary interventions. Next slide, please. And many systems were actually starting to focus on what are we going to be doing differently for this group of patients. It's not just about an acute frailty unit, it's about how we have an outreach service and a support service that actually appropriately avoids those people coming up to the hospital. But the crucial thing for me in all of this was making sure that people are measuring outcomes, both at the patient level, the service level, and at the system level. That to me was a big gap over the last 3 or 4 months. It was very difficult. It leads into our information systems not sharing appropriate clinical data. It also feeds way back to the National Service Framework, is why didn't we have a unified data assessment, a clinical assessment tool such as the Inter-Eye instrument, which they have in New Zealand, that would have been providing this information on a regular basis and being able to feed back into systems for learning for the future. Next slide, please. I think that might be my last slide. It was my last slide. So that was a very quick canter through. Sorry if I've taken a little bit longer. Thank you.
No, really fine. Thank you very, very much. Really appreciate it. Really useful presentation. For me, it brings together that kind of link between same-day emergency care, 111, and frailty. And it's all about, isn't it, us managing our patients in the right place first time, in the right setting. So thank you very much. So 2 presentations left. We'll go to you just for 10 minutes on a local example of South Warwickshire, which I think we'd all put up within the region has been an exemplar of urgent and emergency care. So Jyoti will give us a rundown of the South Warwickshire experience of frailty and SDEC, and then we've got Cliff Mann at 11:15. Over to you, Jyoti.
So thank you very much, Dan, and good morning, everybody. Hard to follow Ian always, but I'll try. So what I'll do is take you through some PDSAs. We can have the next slide, please. Some PDSAs we have done and how we have actually used information from the WOMAS, which is West Midlands Ambulance Service Safe Triage information, to take the patients to the right place first time, including the same-day emergency care in frailty, and tweak the PDSAs as we went along to deliver, the right care to the patients to the right specialist area first time, and to deliver hopefully the care at the right at home if possible, which became a necessity during COVID. So the principles we actually used is that over 90% of all the patients over 75, and this information has been available all the time for us, they are brought in via ambulances, whether they are GP referred or self-referred. Usually they all come to our EDs via ambulances, and they have a good triage done by the paramedics before they come. So I'll take you through those, some results and some limitations. Next slide, please. So this is the view on your computer screens of a safe triage from WOMAS. So what it gives you is a list of patients who are on their way to your acute hospital. So you can view this information only after they have made the decision to convey. So what it tells you is the sort of patients have taken off the names, but you can get some information there. You can get the age group, you can get what the primary reason why they called the ambulance for, and what the impression of the paramedics was once they have done the assessment. And there is a series series of PDFs, as you can see. And if you open the PDF, you can see the entire paramedic clocking sheet with full details of assessment. And sometimes this is actually a very, very high, not sometimes, most of the times it's actually very high quality, very, very comparable to our clocking of the junior doctors. Next slide, please. So we have used this information and we have the screen displayed in our frailty assessment area in Warwick, where you have the entire MDT. So from the screen, we actually look at the sort of patients who we could, bring them. So we wait in the ambulance drop off before they come, and then we used to pick them up from there and bring them straight to the frailty assessment area, use the MDT to design to assess them, and bypass. Definitely the rest of the ED was bypassed. They would never get into the ED. From the ambulance drop off, they would come straight here. Following assessment, they would either go home or they would go to an acute frailty, which is a short stay ward. So that was what we've been doing. The next slide, please. So we tweaked that a little bit more as we went along, and we said, right, this was PDSA 4. Instead of us actually spending time going physically and bringing the patients from ED, we said we'll bypass it completely. We gave our paramedics Consultant Connect, which is simply a communication system which goes through a series of four phone numbers before it drops off into a void. So they are able to communicate directly with our frailty team and then have the conversation and be able to say whether they want to bring the patient to the, drop them off in frailty assessment, or maybe in some cases it needs to go to ED. So, but they are able to communicate directly with the team and completely avoid going to ED and acute medical unit. Next slide, please. So doing those two PDSAs, we have shown that we have increased the direct conveyances to the frailty SDEC. Next slide, please. We have increased the zero length of stay, means more patients are being managed as SDEC than before. Next slide, please. We have increased our 1 day length of stay, which is our short stay. Next slide, please. Increase the 2 day length of stays. Next slide, please. And on the whole, decrease the average length of stay. So we were doing all the right things. Next slide, please. And we have hugely improved the A&E 4-hour performance, which is no surprise. I must emphasize once again here that this is not the reason why we did this PDSA. This is a byproduct of doing the right thing. By getting the patients to the right place first time, this is a byproduct that you get. Your performance in ED improves dramatically. Next slide, please. So the outcome of the Consultant Connect calls, so we had a good 205 calls made by paramedics directly to the using Consultant Connect. And as you can see, 77% of the time the calls were actually answered. And when they were answered, they were triaged to the right place, either directly to frailty in 60% of the cases, to the ED sometimes, to the community sometimes, and to self-care. And even if they did go to ED, it was mainly for some suturing or some gluing, and then they would follow from ED, the frailty would still pull them. So, but the only problem was when a call was made, actually, it was very successful, but the calls were made, only about 10% of the time. So there was a good 90% missed opportunities to do much more of this. Next slide, please. So, this is the next tweaking to our PDSA. So as I said, this safe triage, we could actually view it only after the button was pressed to convey. If we actually could have the clinical conversation before they had made a decision to convey, we thought maybe a good clinical conversation would help us keep the patient at home or in wherever the primary care place of residence is. So next slide, please. So that was what led to the PDSA 5, which basically there's an acute event at home. You've called the paramedics. We have not changed anything in the way the paramedics are taking decisions. We said, if you think the patient can be kept at home, and please do so. If you think they need to go to the hospital because they are acutely unwell and they're the big sick in paramedics language, please convey. Everything in between, no criterias, because criterias make it very difficult. People, they try to fit in or fit out of criterias. We said everything in between, please have a conversation. Now you already have the phone to talk to the frailty consultants. That's already existing. The next thing we added to this was the iSpa, the community iSpa, where actually they have a fantastic service there, and a lot of what needs to support the low acuity patients, exactly the sort Ian described in his previous conversation. Most of them are highly complex but low acuity. So if we can actually provide that service for them at home, then we would be able to do it. Next slide, please. So this is our iSpa, just keep going. So this is our iSpa, where you have not just the community nurses, but we also sit together with the local authority, with links to hospices and end of life services. There's voluntary sector, so everything is actually available at one point. So one call to that will give you a nurse if you want. You can have an increased package of care. You can have a night sitter. You can have, end of life activated, whatever is all there in that. So we are encouraging the paramedics now to make a call there. And once they have, they can access the, the safe triage assessment, they make a decision as to whether they need to do a 2-hour response, divert the call to the frailty assessment area, or ED or GP, or also have a virtual, put them on a virtual ward, which became really, really popular during COVID. So this is what we're doing now. Next slide, please. And these are the early results of the PDSA. So we've had around 25 calls, and where the calls are actually made, 77% have been accepted, and we have managed to keep the patients at home with the whatever they needed. And the rest were either sent to FAA or EDD, depending on what their need was. Again, I must emphasize this is only 10% of the potential calls. There's a big scope to improve the number of calls. There's lots of missed opportunities. And every week we are actually meeting as a group, the paramedics, secondary care, and the community, so that we can see what has been done, what has been missed. And the learning basically is that some conveyances were being needed just for gluing and suturing the wounds. And so our ACPs in the community now are being trained to undertake these. We're also arranging some webinars to understand what the ICC offer is, because people don't know what can be done if you can actually make the call. So we are actually trying to do that. Next slide, please. So this is really what I'm asking the entire whoever is here. How can we make this? How can we encourage this clinical conversation between the paramedics community and the secondary care, so that we have less of these missed opportunities and we are able to do exactly what Ian said in his thing, provide that care at home. We can do it. We know we can do it. It's just we need to have those conversations early and be able to do that. So next slide, please. Questions. Thank you.
Jyoti, thank you so much. What a kind of inspirational presentation, really. I mean, a couple of comments from me. I mean, it's a great example of utilisation of PDSA cycles locally, and each time improving the process and tailoring it to make it better and better for patients. The SPC charts and the utilisation of data. I thought the safe triage view was something that we all need to think about how we can take that forward. And that bit I said at the end of Ian's presentation about 111 and SDEC and frailty all linked together. This is a brilliant example of that. You're linking all three, and how do we, as a region or nationally, think about taking the real learning from your work and bring that into the 111 work to prevent admissions and stream direct to SDEC. So there's lots for us all to think about, and you've had a whirlwind of comment on the chat, so that's fantastic. And controversially, we're on time at 11:15 as well, so it's definitely not my organisational skills. So I'm going to a final presentation is Cliff, and Cliff Mann's our National Clinical Director for Urgent and Emergency Care, and he has a number of roles, one of which is lead on the same day emergency care, and we thought brilliant to hear from Cliff at the end. How we for 2020 for SDEC. Microphones are muted, if that's okay.
Thank you very much indeed, Dan. I hope you can hear me all right.
Yes, we can.
Great. So I'm just going to take you through an overview of where we think SDEC is currently sited. The programme board for SDEC has been running for about 18 months now, and early on we had quite a lot of feedback from various key stakeholders. We worked quite well with the Ambulatory Emergency Care Network, and importantly we ran 7 regional workshops last year. So many of you were cited on the ambition that we have around SDEC. It's been in the planning guidance for the last 3 years, and in the long-term plan, and the ambition up until last year was to move SDEC to being at least a third of the acute medical take, whereas in most places it was sitting around a quarter or less. So if we go to the first slide, please. So we've spent a lot of time discussing criteria, and this touches very much on what Jyoti was saying. And you can either have endless lists of SDEC amenable conditions, or you can have exclusion criteria, etc. Where we've landed this overall is to say that there are definitely reasons to admit patients to a hospital, and they can be largely broken down into reasons of physiology, therapy, investigation, observation, and function. And this was put out early during the COVID pandemic to make sure that people were properly cited on why people needed to come into hospital, because obviously at that time we were very concerned about our capacity. But actually this makes a good aid memoir for SDEC, because basically we want people to regard SDEC as a default option that should always be considered. It may not be appropriate, and these are the most likely reasons why it wouldn't be appropriate, but for people always to be minded on the fact that SDEC has huge potential for many patient groups. Next slide, please. So we picked up on the work of the Royal College of Physicians, the Society of Acute Medicine here. Obviously, most of what we're doing is plagiarising the good work of others and putting it together into a cohesive package so that people are cited on what we think is the best of each of those offers. And touching again on, I think, what both Ian Sturgis and Jyoti was saying is that we cannot overestimate the value of the clinical conversation as being the best reason and the best way into an SDEC service. Using various scoring systems, all the rest of it has been tried. They have a specificity and sensitivity that makes them less appropriate for certain patient cohorts and certain sites. If you want to use them, that's fine, but we would simply say that nothing quite gets us to the heart of the matter as that clinical conversation. I think if we have the next slide, it should give us a yes. So we obviously have renamed ambulatory emergency care units as same-day emergency care units, and that's for the main reason for that being is that you don't have to be ambulatory in order to benefit from it, as indeed the work of both Ian and Jyoti and their frailty patients has absolutely seen. And the other thing we sort of realised didn't actually exist on the RCP algorithm is the next point. Next slide, please. Which is that you can go home from SDEC. You don't have to go from SDEC into any other part of the hospital, and in fact the majority of patients, probably at least 2/3, probably 80% in many sites, will go home. The fact you don't go home from an SDEC doesn't mean to say it's a failure. It just means to say you've set the bar quite high, and that's fine. Importantly also, SDEC is not a unit. It's a model of care, and it can happen anywhere in your hospital. Indeed, it can happen outside of hospital as well. But in particular, it mustn't be regarded as if you're not in an SDEC unit, it doesn't count as SDEC. Next slide, please. So this is just what we're sort of aiming at in the planning guidance. We always get about 3 bulleted points, and this is emphasising the need for SDEC provision 7 days a week, basically making SDEC the default pathway, and doing what everybody else has described, where you want to reduce the numbers of people with an overnight stay, with a consequent increase in people who are going to be staying 2 and 3 days as a proportion of the overall admissions. Next slide, please. So there are 2 key routes of entry into same-day emergency care. The first is the direct entry, and we're keen to promote this. This is from your GP, from a district nurse, or from a paramedic, and many systems have got plans in place and actually operational services. I think of Oxford and parts of the East Midlands, where paramedic to SDEC is a well-established route of entry into the hospital. And then there's streamed SDEC, or indirect SDEC, as I'm going to call it in a moment, which is where you have actually managed to get as far as the emergency department or acute medical or surgical unit, and then it's realised that you would be a suitable patient for SDEC. Next slide, please. So one of the reasons underpinning the challenge here is that we had about 6.4 million patients admitted last year, of which almost 5 were from the emergency department and 1.5 from the acute medical unit. And we only have 95,000 beds, and currently we've actually got about 88,000 beds, so even fewer beds currently in operation now than we had last year. So 1% of the patients is actually 64,000, which is 2/3 of the total number of beds. And so you can see that there is a huge leveraging problem in terms of small changes in admission can rapidly overwhelm our bed stock. But the reverse is also true. So small reductions in our admission rate can have a disproportionately beneficial impact on our bed occupancy rates. Next slide, please. Oh yeah, this is. So this just highlights the fact that SDEC is part of what we're trying to do here, amongst many other things, which look at reducing attendances where warranted to the emergency department, creating greater opportunities for 111 to book into hot clinics and same-day emergency care, etc., etc. So I don't want people to think the SDEC is the only game in town. It's one of the things that we are using to improve services for patients. Next slide, please. So these are the type of indirect access to SDEC. So these are patients who are likely to have arrived somewhere and have got these types of conditions. These are sort of pathway SDEC. That's fine. Next slide, please. This is what we would prefer to see more of, which is the direct access from, as I said, the 111s, the GPs. Importantly, the third box down, direct senior to clinical advice. Is absolutely essential, and working with the RCP, they're very keen to promote this, that every specialty should have a consultant of the day that's available, in the same way that Jyoti was saying that they have a frailty specialist available at the end of the phone. We would like a specialist for each particular service in your hospital to be available at the end of the phone, because in that way GPs can have confidence to manage patients in the community or defer their presentation to the hospital to an appropriate time and place, ideally a specialist run clinic, and this prevents people turning up in the EED who then simply has to act as a middleman trying to negotiate a specialty opinion either there and then as a result of having to admit the patient to the hospital or arranging for follow-up, which is often quite difficult because primary care controls the referrals into secondary care for non-emergency reasons. So this is an important change, going to the consultant of the day model. And next slide, please. So this just highlights the fact that we want to do everything we can to increase the direct SDEC and reduce the proportion of indirect SDEC. We don't mind if the actual volumes go up, but we'd like the proportion to go down, because in that way we cut out the middleman. And cutting out the middleman is much better for the patient who doesn't get passed from pillar to post, and is actually much better for the service because we release a resource and therefore there's an opportunity saving. Next slide, please. So this is work done with the Ambulatory Emergency Care Network, and this demonstrated that looking at 750,000 patients over the last couple of years, 80% are discharged from an SDEC unit within 6 hours. This is quite important for the modelling of the size of your SDEC resource, because with 80% being less than 6 hours, you should be able to manage 2 to 3 patients a day through each of your SDEC pods or cubicles, if you like. Next slide, please. In terms of the size of the prize, the estimate and all the modelling suggests that we can definitely achieve a reduction in bed occupancy equivalent to 4,000 beds per day, or 4% reduction. This would potentially take your occupancy from sitting at, say, 94% down to 90%, which in and of itself would have a massive benefit for your ability to bring in all your elective patients on time and admit patients from the emergency department in a timely fashion also. Next slide, please. Importantly, it's not about a zero-sum game so that the SDEC patients get all the benefit and the non-SDEC patients lose out. This analysis done by NHSE last year demonstrates basically that the more SDEC that happens at an individual site, the greater the reduction in the ED length of stay for those patients who actually do need to be admitted, which makes sense because if you're doing a lot of SDEC, you will have a lower occupancy rate. With a lower occupancy rate, you'll have better flow from your ED. So this is about a win for the patients that don't need to be admitted and a win for the patients that do. Next slide, please. So this is data from the SAMBA audit, so the Society of Acute Medicine, their winter data just this last winter gone. They looked at over 1,200 patients in the SDEC units and demonstrated that this is an extremely safe and effective form of care. So the blue bars you can see are the percentage of SDEC patients with various news scores along the y-axis. Towards the interchange of the x and y axis, that's a news score of 0, so no physiological derangement. At the far end of the y axis, you've got a news score of 4+, so that's quite substantial physiological derangement. And obviously you see fewer of those sorts of patients in an SDEC, but not terribly few. There's still a large number of patients with high news scores, or relatively high news scores. And you can see it's the very small light green bars that are those patients who have to be readmitted within the next 7 days. And that the numbers are really small, even for the higher physiologically deranged patients. And so we are really confident that the way, not just the theoretical way, and not just the way it would happen if you were running a clinical trial, but this is basically registry data reflecting the real world. And in the real world, people are delivering same-day emergency care in a highly safe way. Next slide, please. Equally important, if not more important in many ways, is the patient experience and feedback. And this is work the Ambulatory Emergency Care Network have done using emotional mapping to look at how patients feel at each stage in the journey, prior to arrival, right through to during treatment, and then after discharge. And I think what's convincing about this data is that whilst nearly all of it shows that most patients, most of the time going through SDEC, feel it's a really good thing, there's always a subset of patients who are concerned, worried, nervous, anxious, etc., etc. And so we're not pretending that there's a complete panacea around SDEC. Just like any other medical process, patients will have concerns, legitimate concerns, and we need to be always focused on identifying those and managing them. But this overall shows that SDEC is extremely well received by the patients who go through those pathways. Next step, please. So this is just to point out to you that we have actually understood that there is a capital cost to delivering SDEC. Although SDEC isn't a unit, you do need physical resources to be able to deliver it. You also need revenue resources, and that's a separate conversation. But we are modelling SDEC at the moment and submitting bids to Treasury and the government even as we speak. And you'll be aware that this year £450 million has basically been allocated to emergency department and same-day emergency care type services, and letters have been sent to all the regional finance directors and down to each trust director at the moment for them to be cited on how they might make application for these funds to increase the amount of same-day emergency care, as well as other aspects of changing their UEC offer. Next slide, please. And I think this might be my last slide. We can now actually count SDEC, and I can't overestimate, the importance of this particular aspect of the work. So we've struggled for some time to be able to record this at each individual site. Some places record it using the ECDS, some by using the APC, and some still use the outpatient data set. Let me be quite clear, the best way to record it is ECDS. Outpatient data sets are really data poor, and it's very difficult to understand anything about case mix or what happens to your patients if you use the outpatient data set. APC is much better, but it has two problems. The first is it doesn't record times, it records dates quite well. So it's good at length of stay over 1 day, but it's not good at length of stay less than 1 day. And more problematically for us, it only records the discharge or final diagnosis, not the diagnosis that the patient presented as a differential. And so you can end up looking as if you've done an awful lot of CT scans on people who had no abnormality detected. And what you don't realise is actually that most of those patients were query subarachnoid hemorrhage and therefore absolutely needed their CT scan, even though you would expect the pickup rate to be well under 10%. So using this tool, which we've now just released into the system and will be going, but will be available on the Futures website very shortly, will allow every site to be able to drill down into its own SDEC data. And importantly, it doesn't actually matter in the short term which of these data sets you're using, because you can use the trends to see whether you're doing more of what you did using the method that you recorded on, or less of what you did. And you can see that there's quite wide variations. This is, I think, a screenshot of London. There's wide variations in the proportion of, in the absolute amounts of SDEC, in the proportion of SDEC. But the thing we're most interested in overall is the trend data. Next slide, please. Fine. So I will stop there, Dan, and thank you very much for the opportunity to present where we are in SDEC.
No, Cliff, thank you. Thank you very much. I mean, really helpful for everyone to hear the national context on SDEC. There's lots we all need to be taking away. I love the specialty kind of consultant of the day is really important for all of us to take away, and increasing that proportion of direct access to SDEC is going to be vital moving forward. And all of this is about how we reduce our bed occupancy safely, how we reduce crowding, and then how we minimise and really avoid corridor care, which is something that we all know is the right thing to do, and we strive to continue to do that, especially during COVID. Just for me to round up over the next minute, really. Firstly, I think everyone hopefully will agree that there's been really some fantastic informative speakers over the last hour and a half, and I think we're all going to have one or more, hopefully multiple points we can take back into our own practice, into our own trust to help and improve the care that we deliver. Next slide, Lauren. And it's the last slide for me. It's a thank you, really. It's a thank you to Lauren for steering the ship. She knows I'm IT illiterate and she's very good with the timekeeping, so thank you. Thank you to all the speakers again for giving such informative talks over the last hour and a half. And finally, a thank you to all of you who've attended and taken the time to join us today. We're really keen to take this forward, really keen to learn from each other. We'll send out the slides, we'll send out a recording of the last hour and a half, and then we'll do a follow-up, kind of taking on board the questions and answering them as best we can. Okay, thanks very much, and see you all soon. Bye-bye.